Welcome back, everybody. As was mentioned before, in this third section, what we're going to be focusing on is the disorder, I guess the common classification of disorders called schizophrenia. Now, technically, there are actually different types of schizophrenia that are out there. We're not going to be discussing the different types in today's class, but instead, we're going to be focusing on some of the major symptoms, the treatments, and really the differentiations of kind of schizophrenia ideas from other concepts that we often link to this particular disorder. And when we're talking about schizophrenia, one of the first things we often have to do is discuss what schizophrenia actually is not, because very often people will misconstrue specific symptoms that others are manifesting, or when they're trying to talk about schizophrenia, they'll kind of embed a number of things into schizophrenia that aren't actually a part of this particular disorder. So, one common thing that people kind of assume is based in schizophrenia or linked to schizophrenia are multiple personalities. Having different types of selves, thinking of yourself as multiple individuals, or even kind of having all these different people pop up within you, which is stuff we kind of associate with multiple personality disorder, is nothing like schizophrenia. People with schizophrenia do not have different selves. They think of themselves as their own individual being. It's just there are a lot of things that they're experiencing and a lot of things they're doing that's very different from the norm. Another thing that we often relate schizophrenia to are two kind of emotion based disorders called sociopathic disorder or sociopathy, or another thing that's related to is antisocial personality disorder. It's not that individuals with schizophrenia inherently have anger, frustration, or hatred for other individuals. It's also not that individuals with schizophrenia have no emotional connections to other individuals, or I guess no feelings of sympathy or empathy for individuals within their environment. In fact, there's a number of people with schizophrenia who are extremely emotionally involved in their environment, even though I guess technically there are some people that are kind of separated from their environment as well, and we'll talk about them later on. But when we're talking about schizophrenia, again, it's not this lack of emotion or being different people that we're looking at. Instead, what we're looking at with individuals in schizophrenia or who are diagnosed with schizophrenia is a real break from reality. And this break from reality can be cognitive breaks or emotional breaks. But when we look at these individuals, what we see is they just stop seeing the world the way most people see it. If you want an example of this, you can actually see it in the picture in this particular slide. So you see a man in the upper left hand corner who drew his own cat when he started developing symptoms of schizophrenia. And as he progressed in this particular disorder, you can go from left to right and then from bottom left to bottom right. You can see how his particular impressions or his interpretations of his cat actually changed. All four of these pictures in his mind were true pictures of what his cat looked like as he was kind of progressing in this particular disorder. And that's what we see is people breaking from reality, seeing, experiencing, essentially doing things that people don't often display. Now, fortunately for us, with this severe break, it doesn't happen that often. Only about 1% of the population is afflicted by this. Of course, once you have this disorder, it doesn't just go away. There's no magical pill that can reverse the effects of schizophrenia. There's some things that we'll talk about later can help treat some of the symptoms, but this is kind of a lifelong disorder once it's there. It just fortunately only happens to about 1% of the population. We know there is a genetic link, but we don't believe this particular genetic link is in the X and Y chromosomes because we do know that men and women are fairly equal in the prevalence of this disorder. Men technically have slightly higher likelihood of developing schizophrenia. It's about a 7 to 5 ratio, but they're fairly even with each other. When we look at when this particular disorder pops up, this is another thing that's really surprising to people and another reason why it's so enticing. So we see individuals only developing schizophrenia between about the ages of 16 to 25. That means for most people with schizophrenia, they haven't manifested any symptoms up to that point. And that's really terrifying if we think about it. I mean, imagine living a fairly normal life all the way up into high school or even through high school and college and then suddenly starting to experience things in a peculiar way. Now, sometimes the onset of schizophrenia can be very drastic, so it just hits you like a rock, or sometimes it can slowly, gradually accumulate where the different impressions or the different changes in cognitions can build with time. Either way, the fact that you've lived a very long life without any symptoms and suddenly started manifesting them is really kind of uncomfortable for a lot of individuals. Now, if you've got family members who do have schizophrenia, you are, I guess, technically probably a higher likely chance of having, or you do have a slightly higher likelihood of developing schizophrenia than other individuals. But even then, unless you have two parents with schizophrenia or an identical sibling with schizophrenia, the odds of developing this specific disorder are fairly low. We'll talk more about those causes a little bit later and those links. But first, we want to spend some time talking about kind of how we classify this disorder in the DSM. Now, in the DSM, in order to classify somebody as having schizophrenia, what we're looking for is specific symptoms. In fact, people need to have at least two types of schizophrenic linked symptoms in order to be diagnosed as having schizophrenia. Now, as I mentioned before, each kind of pairing of symptoms often gets defined as a different type of schizophrenia, especially when we talk about the severity of these symptoms. We don't want to go into detail of that. It's just not something that I need you to know, and honestly, it's going to be something that's quickly forgotten. Instead, what I want to talk about, though, is just the symptoms that we're looking for when we're qualifying somebody as having schizophrenia. One of the first symptoms that most clinicians are looking for when trying to diagnose somebody is hallucinations. These are some type of kind of a perception of something that's going on in the environment that's not actually there. Now, we'll detail kind of the different types of hallucinations that can occur in a little while, but know that this is one of the big things that we're looking for as clinicians when diagnosing someone. Another big thing that we're often looking for is something we call delusions, or they're often sometimes called thought disorders, where people's perceptions of reality, their understandings of what's going on, is very different from the norm. Now, again, these delusions can come in a number of forms. We'll detail these in the next slide. But know again that delusions is the other big thing that researchers are looking for, or clinicians are looking for when diagnosing somebody with schizophrenia. Some other symptoms that also might pop up are incoherent speech, grossly disorganized behavior, and a breakdown in emotional responses or social behaviors. Now, incoherent speech and grossly disorganized behavior have also often been linked to drugs and other types of neurological disorders. So, if people are just displaying incoherent speech and grossly disorganized behavior, more often than not, clinicians will look to other things first before they start thinking schizophrenia. We talked about two specific disorders, actually, they're called aphasias, Wernicke's and Broca's aphasia earlier, that could be linked to kind of this incoherent speech. But in studies over the years, we've also found other biological links that can possibly cause these things. And there's another thing that often causes these things as well, and that's drugs. So a number of screenings, a number of questions are asked if people are only displaying those two particular behaviors. Again, in addition to that, the other big thing that can sometimes pop up are emotional responses that aren't there, or what we also sometimes call social withdrawal. Now, more often than not, though, when we're looking for diagnosing schizophrenia, again, we're looking for hallucinations and delusions. And in fact, technically, if the hallucinations or delusions that a person's experiencing are strong enough, they're really profound, that you don't need any of the other symptoms to qualify somebody as having schizophrenia. So we look for these things again to diagnose somebody with schizophrenia, but there's lots of other qualifications or lots of other separations that we can make when discussing the type of schizophrenia that somebody has, or just the specific instance of schizophrenia that one particular person is actually experiencing. When we talk about these symptoms, one of the things we first want to do before we go into many more details on them is actually talk about how clinicians qualify the different symptoms that people are manifesting. In schizophrenia, what we often want to do when describing what somebody's experiencing is categorize their symptoms into one of two groups. Now, technically, there is actually a third group that we call disorganized symptoms, but the two main ones that clinicians are looking for are called positive symptoms and negative symptoms. Positive symptoms are not good things. I know positive, we often affiliate with positive as in good things. or good feelings, but that's not what these people are experiencing. Instead, when we're talking about positive symptoms, we're talking about behaviors or cognitions that these people are displaying that a normal person, or at least somebody who doesn't have schizophrenia, does not actually display. Positive symptoms are common in a number of different types of schizophrenia, but again, the two more prominent ones that we're often looking for are delusions and hallucinations. Again, we'll talk about these in the next slide a little bit more. Negative symptoms, however, are different from positive symptoms in the fact that when people display these, they're actually not really displaying anything. In fact, what they're doing is lacking in display of normal behaviors that other people usually exhibit. So social withdrawal, and a lack of motivation, a lack of movement, lack of a lot of different things is qualified as a negative symptom of schizophrenia. And if people can't categorize the symptoms that they're detecting into either of these categories, again, we call them disorganized symptoms. We'll talk about them in a little while. But for the most part, when we're diagnosing schizophrenia, these are the two categories that we're interested in: positive and negative symptoms. As was mentioned in the last slide, when we're talking about positive symptoms, the two most common ones are hallucinations and delusions. Hallucinations, as was mentioned before, are some type of perception that a person has or an interpretation somebody has of something in the environment that's not actually there. Now, more often than not, when we think of hallucinations, we think of auditory and visual ones, even though technically people can have all types of hallucinations. So you can have smell hallucinations, you can have touch hallucinations, you can even have taste hallucinations. But when we're talking about the most common one, the primary one that people experience, auditory hallucinations are much, much more common than visual ones or any other ones that people actually will experience. When we talk about auditory hallucinations, though, we need to know that there isn't one particular theme or one particular thing that people hear. Sometimes individuals hear voices, sometimes people hear sounds, sometimes people hear screaming or other random human events. Oftentimes people hear actually a combination of these things when they're experiencing these auditory hallucinations. Now, as a note of caution, understand that all of you probably have heard an occasional thing that others swear isn't there. That happens. Our brain can pick up on these things. But for people with schizophrenia, these experiences are much, much more common. They occur on a regular basis for these individuals. And what's really interesting is not only do we see them actually trying to display it, or I guess manifesting the recognition of these sounds, but when we look at the brains of these individuals who are experiencing these hallucinations, we do see in some of their higher brain regions, in particular their auditory cortex, where they're starting to process what they're hearing, we do see brain activity that's indicative of the processing of some type of sound. Even though the pathway from the ear to the brain is inactive, somewhere along that glitch, or along that path, there's a glitch that's causing these activations. Again, we don't know why it's happening, how it's being triggered, but these things do happen a lot when people develop schizophrenia. The other type of positive symptom that people are displaying are, again, those delusions, where people have some type of cognition, belief, or idea that's very different from the population. Usually with delusions, what we like to do is classify them into different categories. There's three prominent categories that we tend to put things into, and if we can't put these particular delusions that people are experiencing into any of those categories, we put it into a fourth category called bizarre delusions. The three main ones, though, are delusions of persecution, grandiose delusions, and delusions of reference. Delusions of persecution involve this idea that there's some type of entity, either an individual or a group, that's somehow conspiring or out to get that individual. Now, oftentimes the idea of what they're out to do is kind of removed from the individual. So they don't know what the person or what the group is trying to do, but they just know in their heads that there's some sadistic attempt to hurt them or harm them or kind of immobilize them in some way. One of the classic ones that people will often manifest is that the idea that greater powers or higher powers within a country or within a society are somehow conspiring against them. So in the United States, one of the common things that people hear about is CIA infiltration, when the government's trying to listen to what they're saying or trying to spy on them through hidden cameras in the environment. Another type of delusion that commonly occurs are these grandiose delusions, where people see themselves as exceptionally important. Now, sometimes grandiose delusions can be very specific, very common, like the belief that they're an alien, or that they have some special power, or that they're, say, the Queen of England. Of course, the Queen of England believes that, but she's the one person that obviously gets to. Everybody else would be experiencing that grandiose delusion if they truly believed they were experiencing those things. There are some weird ones, though. In fact, I had a fellow colleague who had a client who had this grandiose delusion that he was capable of impregnating women just by flicking his thumb and forefinger at them. So he would walk around the streets very diligently figuring out which women he wanted to impregnate and proceed to flick his fingers at any woman that he thought was really worth the time and the effort. That's really interesting because it seems weird, but he truly believed that he had this particular ability. Another type of delusion that's very common are these delusions of reference, where people will read things like newspapers, watch television shows, listen to conversations, and pick up on connections that really, in all reality, aren't there. Now, it's often enticing for people to try to think that these people are truly seeing codes or picking up on things that we're just not capable of seeing. But there's no statistical evidence to show that when these people are having these delusions, that they're actually picking up on things that are actually there. Again, though, if we can't classify delusions into any of these categories, we do have one different one that's out there that we call bizarre delusions. And these are ones that really do seem very random. Classic case of this, if we want an example, was another, colleague of mine who encountered a client who believed that somehow in the middle of the night her organs had gone missing. Essentially, she had just disappeared from her body. It wasn't that somebody had stolen them. It wasn't that they abandoned her. It was just they were gone. And she was terrified because she thought and kind of knew that she needed them. So she was convinced that at any moment she would just kind of collapse and die right on the spot because she didn't have a heart or lungs or anything else that was required for living. Again, these delusions don't necessarily make sense. In fact, they almost never make sense. And what's really frustrating for a lot of individuals is that they realize these delusions don't make very good sense. In fact, they also oftentimes realize the hallucinations that they're having don't make sense. But unfortunately for them, the hallucinations and the delusions are so real in their heads, it's very difficult for them to discount them when they're actually experiencing them. Again, though, just like we have positive symptoms, we do also have negative symptoms. So let's talk about those now. Now, again, when we're talking about negative symptoms, what we're talking about is behaviors or cognitions that these individuals are just not displaying that a normal person actually does display. If we want to talk about lacking behaviors, one of the major things that we see within individuals is that they don't necessarily have a tendency to display emotions. And we give this a very special name. We call it flat affect. And you can actually see this in the picture on your right hand side. So this individual who theoretically has schizophrenia is not displaying happiness, he's not displaying sadness, not displaying anger, frustration, or anything. In fact, this flat affect not only exists most often on people's faces, but it also is included in other characteristics that we usually kind of subtly display without even thinking about it. So most often, people with schizophrenia don't change their tone. They also don't change what they're stressing. So you've heard me kind of highlight a couple words, not only in this class, but in every one that we've talked about. And by doing that, I'm hoping that you can pick up on some of the key concepts or the key ideas of where to focus on things, or kind of just understand the cadence to to understand what I'm trying to accentuate or what I'm trying to stress. Well, for individuals with flat affect, that never happens. They just don't provide any of the social cues that we often display, hence why it's a negative symptom. The other type of negative symptom is, again, an emotional one, and we actually have a name for this. It's called anhedonia. So not only do these people not display emotions, but often they don't experience emotions. And more often than not, the big lack of experience is in positive emotions. So with a lot of individuals, when they start experiencing schizophrenic symptoms, not only do they kind of have this weird anxiety and fear, but everything they used to enjoy becomes less enjoyable. It's not to the point of a depressive person's lack of, or lack of positive emotions, because again, with depression, they have many more negative emotions that we look at than positive emotions. But for these people, it's just like they just don't experience any type of emotions. And what often we see is this flat affect, this inability to communicate, this lack of positive emotions, often also leads to one last major negative symptoms, and that's social withdrawal. People just tend to lock themselves in their rooms because of the different hallucinations or delusions that they have, in combination with the fact that they start to realize they're not capable of communicating with people very effectively. So again, all negative symptoms are things that these people are really lacking in their typical behaviors or in their repertoire of daily activities. As I mentioned before, though, in addition to having these positive and negative symptoms, sometimes there are symptoms that people manifest that just don't qualify as either of those. That disorganized speech that we talked about earlier is a classic example of something that's often qualified as a disorganized symptom. And in this disorganized speech, there's certain things that we always see. More often than not, even though it seems to be somewhat coherent what people with schizophrenia are saying, oftentimes what they'll do with disorganized speech is jump from topic to topic. So they'll understand sort of what's being asked of them, they'll sort of respond, but there's just these loose associations in this ease of jumping from one topic to the next without worrying about it that most of these people actually have. Another thing that will often happen with them is they'll just get derailed in the middle of a conversation and just stop. So they could be talking and just like that, pause, have this break in their conversation. And to get a sense of what this is like, what I'd like you to do after we talk about disorganized behavior is stop the slides and actually watch a video of an example of a woman who's experiencing schizophrenia. She's displaying clear disorganized speech. She's also talking about hallucinations, probably delusions as well. So you can see what the true symptoms of disorganized speech are. But before you do that, there's one last disorganized symptom I want to talk about, and that's disorganized behavior. And this behavior is very similar to the one that you see to the right. So what we often see with these individuals is they can display something called catatonic behavior, where they will get themselves into a posture, a stance, and stay there for an extremely long period of time. Now, sometimes people will do this when they're sitting and staring off into nothing. Other times they'll do this when they're laying down. But what's really interesting is a number of individuals will actually get themselves in unusual postures like the woman you see in the picture and lock themselves there for extremely long periods of time. So we're talking about not only minutes but sometimes even hours where these people will stay in this catatonic state. We again don't know what's triggering it. We don't know why it's happening. We know that these people are experiencing some sort of pain when they're doing it because, well, their pain receptors seem to be active. And not only that, but they do hurt themselves oftentimes when they're doing this. So you'll see blood pooling in areas which can cause bruising or scar tissue to kind of build up as they start to hurt themselves internally by doing this type of stuff. But oftentimes they can't control it. And since it doesn't, again, qualify as really a positive symptom or a negative symptom, we just call it a disorganized symptom. Now that we're done with that, please, again, go to that video, which is an example of disorganized speech, so you can get a sense of really how far-reaching this particular disorder can be. Then, please move on to the next slide. Now, again, as we mentioned earlier, when looking at the causes for schizophrenia, what we see is that this is a very heritable disorder. Namely, when we control for environmental factors, what we see more often than not is that the genes that you're kind of born with, the people you're with, as you develop, is a strong predictor of whether or not you're going to develop this disorder. If we look at identical twin studies, what we see is that if somebody has an identical twin with schizophrenia, the odds of them actually developing schizophrenia are almost 50%. It's half the time you're going to develop it if your sibling has it. Now remember, only 1% of the population develop schizophrenia on their own. So this is almost a 50-fold increase in the likelihood of developing this specific disorder. If you're born to parents with schizophrenia, again, you almost have a 50% chance of developing this disorder. And as the overlap moves down, the odds of you actually developing this specific disorder get greatly, greatly lessened. In fact, if you have only one grandparent with a disorder, the odds of you actually developing it are only 5 times greater than that of a normal person, or 5% chance of developing this disorder. When we look at this, though, I do want you to notice that the overlap is not 100%. That implies that there's other things that are out there that are impacting this. Another thing that greatly implies that there's other stuff out there is the fact that we still have not been able to link a specific gene in the human body to the development of this disorder. So lots of people have, in addition to looking for genes that we could possibly link to schizophrenia, decided to look elsewhere when trying to figure out the cause of the deterioration of the mind. And one of the things that we've noticed is that when we look at the brains of individuals with schizophrenia, after they've developed some fairly severe symptoms, their brain, makeup or structure is significantly different from other individuals. Most notably, what we see is the area associated with memory called the hippocampus, and the area that supports all of the higher brain functioning that we talked about earlier called the cerebral cortex are smaller than a normal person's brain. And by contrast, kind of as a result of this, the cerebral ventricles, the areas where blood flows through the brain, become significantly larger as a consequence of this shrinking. But in addition to that, what we also see is that the neurons are arranged very differently in individuals' brains when they develop this disorder. If you want to see a picture of this, what you see in front of you is actually a picture of two siblings, identical twins, but one of them has developed schizophrenia while the other hasn't. The one on the left is actually a healthy individual with a normal brain, with the normal size cerebral cortex and the normal hippocampus, which you can't really see in this picture. The identical twin on the right is one that's developed schizophrenia. You can see those two giant holes, and those are actually the ventricles, again, where blood passes through the cerebral cortex, but they're significantly larger than they should be. And as this person probably developed further symptoms of schizophrenia, or as their situation progressed, what would often happen is those ventricles would get even larger. And as those ventricles are getting larger, the brain is continuing to what we call plaque. It essentially has neurons clustering in different ways, essentially becoming very disorganized, and the brain almost looks like it's twisting as it's kind of contained within the skull. So we know that there is this kind of anatomical link between schizophrenia and the brain. But we also wonder whether or not this anatomical link is something that's causing this particular disorder, or it's just a side product of the development of this disorder. The question that often that's being asked is, if the brain structural change is actually causing the symptoms, what's causing the brain to change? Or is there something else that's going on that's causing the mind and brain to both deteriorate at the exact same time? One of the ideas that's been floated around recently is this notion that maybe what's going on is that people at a young age are being exposed to some environmental toxin, or one of the newest ideas is a specific genetic virus that could possibly be essentially putting somebody on the path to have their brain deteriorate when they get older. This idea is something called the neurodevelopmental hypothesis, and we still have not linked a very specific thing to the development of schizophrenia, but there are some suggestions that things like poor prenatal care, difficult pregnancies, a mother's exposure to any type of influenza virus can slightly increase the chances of a person developing schizophrenia. We still haven't found that key element yet, though, even though there is some chatter right now within the community about specific, again, as I mentioned before, viruses being strongly linked to the likelihood of developing schizophrenia in adulthood. We still have to study it more. We still have a lot of unanswered questions, but this is kind of the newest area we're getting into when talking about theorized causes to schizophrenia and how we can kind of look for a genetic and biological or an environmental link to the development of this disorder. Now, as I mentioned earlier, once somebody starts displaying symptoms of this disorder, there really is no way to reverse schizophrenia. Instead, what we do is try to treat the symptoms. And when we talk about treating symptoms, there's a number of different things that we've come across. In the past, what we automatically did with anybody who was experiencing schizophrenia is put them away in a hospital, essentially hospitalize them for the rest of their life in order to protect them from themselves and protect society from them. Nowadays, hospitalization is only used for people suffering from very, very minor symptoms of schizophrenia, or it could theoretically be used for people who are having severe breaks so they could stay in for a very short period of time while they kind of recover from these symptoms. More often than not, though, we prefer psychological or medical approaches to helping individuals. Now, CBT is one of the more commonly used techniques when we're talking about therapy. And there, what we're often doing is trying to help people kind of reinterpret their perceptions or assess their delusions or kind of practice on social skills to find a way to kind of help reconfigure their brain to overcome some of the deficiencies that they're experiencing. Again, with this cognitive behavioral therapy, we're not necessarily removing the disorder, we're just helping people cope with their symptoms a little bit better. For most individuals, though, CBT is not enough. You have to have an exceptionally powerful mind, you have to have very good control over what you're doing, and your symptoms cannot be extremely profound, or there's just no way CBT will actually work. So oftentimes what we do is we pair these therapeutic techniques with some type of medication. And the medications that are applied for schizophrenia are often called antipsychotics, or some people like to also call them neuroleptic drugs. What we see with antipsychotics is that they come in a number of different forms. There are a few different antidepressants. There's a number of anti-anxiety drugs out there. There are a ton of antipsychotic drugs out there. And they're all meant to relieve symptoms of schizophrenia. But what we see, which is really interesting with this particular disorder, as I mentioned in the video that you saw earlier, is it seems like this is really just a game of catch. You got to try to find which particular drug will work. So you toss a drug at the disorder and you hope that it actually sticks. You hope that it actually causes those symptoms to go in remission. Some of them work on specific things like dopamine, others affect glutamate, but no matter which particular type of neurotransmitter you're trying to affect, what you're looking for is something that produces a long-term effect. And this is a major issue that we've had over the long run. Namely, what we've seen with a lot of these drugs is that almost every drug works right away. In fact, when we look at the success rates of drugs when they're taken, we see a profound effect. In fact, if somebody gets a placebo or any type of drug, what we see is a lot of their symptoms for the first couple weeks will go into complete remission. But as time passes, the effectiveness of antipsychotic drugs and theoretically the effectiveness of placebos start to greatly decrease. So it can be a very challenging encounter when you're trying to find the right drugs for individuals, because you have to find one that not only works right away, but one that continues to work for an extended period of time. And that means lots of testing, lots of fiddling, except you don't want to try to kind of fiddle all over the place, because as people go back into remission, these symptoms, as you could probably guess, can have a really profound effect on a person's life. So the dance of trying to find the right drugs is a major concern. Another issue that we have with this particular drug approach is that it seems like the onset of the disorder can be a great predictor in how successful drugs are going to be. Oftentimes what researchers talk about is something called the rule of thirds. Usually when we're talking about schizophrenia, what we hope for is kind of a sudden onset of symptoms, because we know for those individuals who do have that sudden onset, especially if their symptoms are fairly profound when they pop in, usually drugs work really well. For those individuals that kind of have a normal progression, 50% of the time the drugs work, 50% of the time they don't. And for those individuals that have really the slow onset, gradual growth of symptoms, usually for some reason drugs do not work very well. So when we're talking about kind of treating the symptoms of schizophrenia, I want you to just get a sense of how frustratingly complex this particular disorder is. And because we don't necessarily know whether or not the drugs help kind of slow the deterioration of the brain, or whether or not they're just kind of acting on the cognitive aspects of the brain, we're really still trying to perfect our understanding of how neuroscience, how biology really plays a role in this third very big disorder that we're talking about. Now, I know this is a horrible place to end a lecture, talking about a kind of scary disorder, but unfortunately for us, this was the last section that we were going to cover for this class, which means that we're also ending the entire class in this lecture. So we've obviously got the last exam for you to take. Make sure that you study for that. Make sure that you're prepped. But you have no more slides to listen to, no more minutes listening to me drone on about topics. It's all up to you at this point in time. So if you've got questions, please ask. Otherwise, good luck in your studies. Good luck in the exam. Thank you very much for the great semester. I really enjoyed all the effort you were putting into everything this time. And I will hopefully see some of you around. Even if I don't, I wish you all the best in your pursuits. Take care.